check this out, man. This is like the littlest bottle of Tabasco sauce. This is not hot sauce. It's just seasoning. It's crazy. A couple of announcements. For CME, we have everything online. If you have trouble logging in, let us know. But for all your CME credits, you just go online. And all the evaluations and all the feedback you give us in terms of what you liked or didn't like about speakers, topics, what you want next year, because you're all coming back, because it's great to have you. That's really helpful, so go online. Also, if you have a chance sometime during the day to check out some of the vendors, we have near and dear to my heart. We have a bunch of ultrasound vendors. There's actually the Storts rep who has a CMAC. It's a great airway device if you haven't used it. But they sponsor us, they help us out, and they hang out here waiting for somebody to talk to. We're so lonesome. So if you feel like you want to talk to somebody who's hanging out and lonesome and needs a little support, go over and visit them. We're going to stop today around 10:30. Starts this afternoon. There is a neurology workshop in the afternoon at 3 on neuro evaluations if you haven't signed up. I think we have enough room to get a few stragglers. So if you get sick of skiing or you smack your head and wonder what would you do to get evaluated by a neurologist, you can come and see Evie Barklady, who's just awesome and a great instructor. And with that, we'll start. And I'll let you do your stuff. You mic'd up?
Yes, I think so. You guys hear me okay? With or without this thing, I can yell pretty loud. So, first of all, thank you guys very much for having me. When I saw the schedule set up and the fact that this conference was at Stowe, I think I set a personal record from time of visualizing email to time of yes response to come here. So, very excited to be here. For those of you I haven't had the pleasure of meeting yet, my name is Mike Lauria. So I was PJ, so I was a pararescueman in the Air Force for about 6 years, and my job was providing combat search and rescue capability and medical support to various special operations teams around the world. And when I was done with that, I figured I wanted to come back to the Northeast, so I got a job flying for DART. I've been doing critical care transport for them around Vermont and New Hampshire. Full-time for about a little less than 3 years, and then part-time while I've been in medical school, because I'm a glutton for punishment, so I just could not stand the idea of not going through more academic pain and terrible PowerPoint presentations. So I went back to school. In fact, I talked to the VA, and I submitted a claim that said, trying to go back to medical school at 30 was obviously a manifestation of multiple TBIs. And they denied the claim and said that the fact that you wanted to be a PJ in the first place was evidence of underlying psychopathology, and that it didn't really count. But, I have no financial conflicts of interest, but I do have this disclaimer. The stuff I'm going to talk about today is things that I've found value for in the special operations arena, in resuscitation, and I think there's evidence for. But I don't claim by any stretch of the imagination to be an expert or master of any of these skills. I'm still practicing them and still refining them and still trying to learn them as I'm going through school and flying around Vermont, New Hampshire, seeing patients. So. The crux of this lecture is about how I think that we can actually learn psychological skills to perform better in acutely stressful situations. And what I want to do is sort of break it up into 3 chunks. First, talk a little bit about how other organizations have conceptualized stress and performance in the past, in particular the underlying psychological concepts, and then talk about several very specific skills that I think there's a lot of evidence for that you guys can take away and start applying today on the Hill if you wanted to, or tomorrow in clinic. And finally, sort of a bigger view of how I think we can actually incorporate these skills into education. So if you want to dial back the clock to about 2005, I had finished my undergrad at Dartmouth College and did what any level-headed biochemistry major would do, and I enlisted in the military. So I drove my dad to drink, and my mom freaked out a little bit, but it all worked out in the end. It was probably the single greatest experience of my life to date. I got to work with some of the most amazing elite special operations organizations on the planet, and I learned so much from these guys. Besides like the medical skills and the tactical skills, the thing that I really walked away from was the way these guys were able to manage stress in some of the most unbelievable environments on the planet. Some of the most dangerous situations, these guys were able to adapt, and improvise, and overcome, and complete the mission. When the deck was stacked against them, when things were going sideways, they were always able to find this crystal clear path through the chaos. Make the right decisions and get things done. And I thought that was absolutely fascinating. What was cooler was that when you talk to them, I mean, a lot of people think if you watch like these National Geographic specials on SEALs and PJs and Special Forces guys, that were just like naturally like plopped out of the womb and you're like ready to go and like conquer things and manage your stress. And that is completely false. As it turns out, like many emergency physicians and surgeons and anesthesiologists, guys developed behavioral and psychological skills over time. Even if they didn't know the evidence, they were developing these skills over time to manage these situations, which I thought was really cool. So, for example, one of our breachers, so the guy who does all the explosive ordnance and breaks down the door for us, his name was Bull. He was a tatted out 260-pound meat-eating, terrorist-fighting machine. And Bull liked two things: blowing things up and lifting really heavy things over his head. And not surprisingly, he was really good at both. But what he would describe was when he was going to a target or an objective, he would describe actually walking through what the imagery, what the satellite imagery looked like, what the intel said, what his approach to the front door was going to be, what it felt like to pull the explosive charge out of his pocket, exactly how he was going to lay it on the door. He walked through the whole thing in his head before he even got there, which is pretty neat. Others, so some of my sniper friends, the guys who do precision marksmanship, they would talk about how they had designed drills for them to learn how to control their breathing. When they're done running to the top of a building and they need to make a shot at 500 or 600 or 1,000 yards, how do they do that? How do they control their heart rate? Some of my friends who are actually, ironically, PJs and deathly afraid of heights and parachuting would talk about how they actually calmed themselves down, this internal monologue they would have with themselves as they were getting ready to jump out of a perfectly good aircraft going 130 knots, 13,000 feet above the ground in the middle of the night, which is a little bit anxiety-provoking, I might add. And still others would talk about how they manage some of these skills in technical rescue situations or in situations of resuscitation. I thought that was really interesting. But what was even cooler was when we go back to the States to train at places like UAB or shock trauma, and we'd be doing our rotations there in the ICU and the trauma resuscitation unit, the physicians would have similar things that they would do. Not knowing what my friends in the military community were doing, they would have similar things that they would do. So for example, I'll never forget this, one of the surgeons at shock trauma was actually teaching one of the residents, and as soon as the report came in, there was this dude with multiple gunshot wounds to the chest and abdomen. He was hypotensive and then lost pulses as they were landing. As they're coming down the elevator, he's telling the resident, okay, what are you gonna do now? Well, what I do is penetrating trauma to the chest, lost vital signs within the past 2 to 3 minutes. He immediately walked through in his head what he was going to do for a clamshell thoracotomy. As they're pulling out the tray, he explained how he was walking through the steps in his head, what he would imagine the tray to look like, all of the instruments and how they were set up, and what the first step was going to be, and what the next step was going to be. So I thought that was really cool, and I saw these parallels between these two otherwise very disparate worlds. But I still didn't believe it. I thought like this was just psychobabble BS, and there can't be any evidence for this, right? This is just, you know, like tips and tricks that people do, and it makes them feel better, but it can't actually improve performance. And I was dead wrong. There's a ton of evidence in the literature to support this stuff, which I thought was really, really interesting. And actually, if you look at it, there's more evidence for a lot of some of these skills than there is for like half the stuff that we do in the emergency department or back of the helicopter, which is pretty cool. So I think it's helpful in the special operations community, and we've done some research to show this. It's helpful, elite athletes, extreme athletes, sometimes pay big bucks to have psychologists and psychiatrists work with them to develop some of these skills. NASA has come up with psychological skills training programs for their astronauts when they're, teetering out on the brink of oblivion, trying to fix some like little screw on the space station. And I can tell you it's been important here for me in the back of the helicopter at 2 o'clock in the morning when I'm going from Rutland to UVM and the patient decides to crump on me before we hit the pad and UVM rescue shows up. My hypothesis is that it would also be of use here in the emergency department and in the ICU as well. So that brings us to an important question, which is, why does it matter? Like, who cares? And I think it's important, and I think it does matter, because we have tons of evidence to show that acute stress affects performance. Acutely stressful incidents have a variety of untoward effects on how we think and how we act. They can decrease fine motor skills, they decrease cognitive processing, they increase distraction, all kinds of stuff that lead to suboptimal performance. And how at least we think that happens is something we call an appraisal mechanism. This is the psychological academic structure for how we believe this happens. And what we think happens is both consciously and unconsciously, whenever you're faced with a problem. That could be your car breaks down on the side of the road, it could be a pediatric patient is coming in coding, whatever. Your brain consciously and unconsciously does like the self-evaluation. Do I have what it takes to address this situation? Have I seen it before? Have I been trained to deal with this? If you've seen 1,000 codes, it probably doesn't get you too ramped up. When some 65-year-old guy who's having a STEMI comes in with a code, you know what to do, right? You've seen that dozens of times. Bizarre cases that sort of stand out, especially with populations you don't see very often, like the 2 to 3 or 4 or 5-year-old that's coding, right? That probably is a little bit anxiety provoking for a number of reasons. So if your brain believes that it has what it takes, or it does not have what it takes to deal with the situation, your mind perceives that as correct. And we can actually measure physiological changes that occur when people subjectively say this is their psychological situation. So we see increases in peripheral vascular resistance. Your cardiac output stays the same or goes down, your blood pressure goes up. And you believe that you're a little stressed out, this might not go so well. Conversely, if you believe that you have what it takes, you've seen this before, you can knock this one out of the park, no big deal. Or at the very least, you know what, this is going to be really tough. I'm not sure if I can do this, but I've been trained to do similar situations and I'm going to step up and knock this out of the park. Then you perceive it as challenge. And again, we see physiological markers that are fundamentally different from that stress threat appraisal. So we actually see peripheral vascular resistance go down, cardiac output go up, and your blood pressure stay about the same. Like an athlete preparing for competition, that psychological profile will determine physiological parameters, which is kind of interesting. This is sort of a classic, slightly oversimplified model of how we conceptualize stress and performance. Some stress is actually pretty good. Used stress is good. It gets you focused, it gets you ready to go, it gets you ready to tackle these challenges. Too much stress, however, causes fundamental deterioration in various cognitive and technical skills. I have to put a note in here to my friends in the human factors engineering world. This is sort of like a little bit Mickey Mouse. And in reality, the way they've conceptualized this in very complicated, totally nerdy diagrams is like this 3-4 dimensional sphere-like thing that also takes into account the type of stress, physical versus psychological, and a whole bunch of other parameters. But to keep it simple and to understand the concept, this model, I believe, holds up. The important thing that we can take away from this model, or the most important thing that I think is universally applicable, is regardless of the domain, what it seems is there is this crux, this fluctuation point where you go from optimal performance and things start to get worse. The whole goal and what we've learned is that through training and development and exposure, what we can do is we can actually prolong this peak performance. You can perform at your highest at higher levels of stress or more difficult situations, which I think is interesting. So how can we improve that performance? Well, I think there's a couple ways that we can do it, but I think it really revolves around a handful of skills. And what I want to do is tell you a quick story. So I was going through the pipelines, the pararescue training pipeline. You go through selection, and you go to all these technical training schools. You go to survival school, you go to free fall jump school, and you go to dive school. So the military combat dive school has one of the highest attrition rates in the military, and it's very challenging and difficult. But we have been crushing it the whole time throughout the pipeline, so I was going in here with no worries. Then we do this wonderful exercise called one-man competency, which is another phenomenal military euphemism for take you to the bottom of the pool with a blacked out mask, steal your oxygen supply, tie it behind your back, and throttle you again to the bottom of the pool. That's one-man comp. And man, I failed. I failed miserably. I actually passed out. I couldn't find my air supply. I passed out face down in the bottom of the pool. And when they drugged me out of the pool, and I finally started breathing again, which it turns out is probably a good thing, I had to sort of sheepishly drag the equipment off, drag all my stuff off the pool deck and head home. But before I went home, one of the instructors said something very simple to me. He's like, hey man, this gig, this whole dive school gig is pretty simple. You just gotta breathe underwater. You have to learn to use this, apply this to control this, which I thought was very interesting. And that really, really stuck with me. So I actually went home after failing, and before I started training, I actually drank heavily for about 3 days. But after that, I went back to training, and actually the physical training we did not change. What did change was coming up with little tricks and tips and ways you could keep your heart rate down, control the oxygen consumption, and focus on a specific task, i.e. untangle your regulator. And it worked. I eventually passed. But what that led me to sort of eventually come to is these are active cognitive and behavioral techniques that we can apply to help us out. And that shouldn't be too surprising, because this is what we call the cognitive triangle. What we think, what we feel, and how we act are all connected in this sort of neurochemical milieu that's swirling around between our ears. It should also not be surprising, because this is the cornerstone of psychotherapy for people with things like anxiety disorders. It's the modality with the most evidence behind it to help treat some of these disorders. So what I wanted to do was basically take my experience, what I'd seen practically work, overlay that with the evidence, what the data shows seems to help performance. So what I came up with was something that we call PEPS, Performance Enhancing Psychological Skills. And we kept it, we sort of parted down to about 4 things to keep it simple, right? 4 things that I think we can do on a regular basis to help us out here. Breathe, talk, see, and focus. So breathe. So breathing is kind of cool, because if you think about it, it's the only autonomic function that we have conscious control over, right? Like if we were able to just sort of psychologically lower our blood pressure, that'd be cool, and we'd see much fewer patients riding on the helicopter and coming into ED on beta blockers and ACE inhibitors. Unfortunately for the pharmacy companies, it's not the case, but breathing we can control. And we can apply that. You can actually use breathing to blunt the downstream effects of increases in sympathetic tone and activation of the hypothalamic pituitary adrenal axis. That's kind of interesting. How this has been studied is actually in something people call box breathing. In the military, of course, because everything has to be tactical, we call it tactical breathing. And basically what it is it's just applying a series of set 3 or 4 controlled respiratory cycles. So taking a deep breath in for about 4 seconds, holding it for about 4 seconds, let it out for 4 seconds, and hold it out for 4 seconds. And it actually works pretty well. In fact, there's an app that you can get on your phone to do this, but I would argue if you have the mind space to pull out your phone and use a tactical breathing app, you probably don't need the tactical breathing to begin with, because you've got your stuff together. Talk. So this is very interesting. This revolves around a concept that we call cognitive reframing. And I think it's illustrated beautifully by this Cherokee legend of these 2 wolves. So this grandfather is trying to explain to his grandson the conflict that happens inside every human being. And he uses this beautiful metaphor of these 2 wolves. And he basically describes that one wolf is like all the bad things, hate and fear and anxiety and jealousy. And the other wolf is all the good things like happiness and contentment and love. And he says they're always at conflict. They're always fighting one another. And he goes on and on. Eventually the kid, in a very precocious way, says, well, Grandpa, how do you know who wins? And as the legend goes, Grandpa says, the wolf you feed is the one who wins. And I think that's important because the internal dialogue that you have with yourselves in these situations is critical. If you're like, oh my gosh, I'm going to screw up and everybody's going to laugh at me, you're probably right. If you tell yourself that even though this is going to be really hard, I can overcome it, I can do this, I can make things happen, then you're more likely to be successful and you are less likely to commit errors or have problems along the way, which is kind of cool. So just by changing that internal dialogue, you're changing the way that your brain is perceiving the challenge. You're affecting that appraisal mechanism. And what you're kind of changing is things that might otherwise seem impossible, you're making them seem possibly attainable. And things that you're perhaps seem unable to do or haven't done in a long time, you can perceive as possible or able to do. So there's a variety of ways you can set these up, and sometimes people actually change how we set up that internal dialogue. So those phrases, that self-talk, that positive self-talk could be motivational, like the legend that could style, like I think I can, I think I can, I think I can. Or it could actually be a little more instructional, and especially for medical procedures or medical emergencies, instructional seems to work very well. If you can distill down like your steps of doing a cricothyrotomy or placing a central line to a short mantra, your brain will focus on that mantra. It will be positive or instructional in terms of how you're successfully able to do that procedure, and you're more likely to succeed. So if you ever heard like Rich Levitan talk about airway stuff, his mantra for people who are hypoxic is sit them up, jaw forward, all O's through the nose, right? So that would be a very good example of instructional, positive self-talk. Now, at least the research shows that there's additional ways that we should structure some of these phrases. So they should be relatively short. If you're giving like, a paragraph or two like monologue on a particular procedure, that's not very helpful. It should be relatively short. It should be very specific, and it should be positive. So it never really works very well when your positive self-talk is like, don't screw up, don't screw up, don't screw up. That doesn't help, because your brain tends to fixate on that thing that you're telling it. And if that thing is screw up, then that is a negative form of self-talk. You want it to be strictly positive, what you're going to do or what you're able to do. C. So if you've ever watched like the Olympics are coming up, especially like the Summer Olympics, and you watch like a diver or a swimmer or a gymnast or whatever, like before their routine, they're like up there in the blocks or off the mat, and you see them, they look like they're like almost having a seizure. They're kind of like going around this number in their head. What they're actually doing is they're visualizing their whole routine. Just like Bull, that preacher, they're actually going through in their brain exactly how they're going to perform, what they're going to do on the mat, how their dive is going to go. And that is kind of interesting, because as it turns out, if you take people and you fMRI them, when they're actually performing an activity, like playing the piano or knitting or something like that, and you fMRI people who are just thinking about that activity, thinking about their golf swing, thinking about playing the piano or a piece of music, the exact same parts of the brain light up. The signal intensity from the same parts of the brain is almost exactly the same. Which means that when you're doing an activity like this, when you're visualizing a process before you do it, it's like a practice run. Specific visualization of procedures is like a practice run. And I didn't really think about this until several years ago when I started doing it, and at least, anecdotally, I can tell you it seems to help. Like when we land on the side of the highway and we go in the back of the ambulance and someone clearly needs an airway managed, like as I'm setting up all the stuff we need for RSI, I'm like going through in my head, like, this is what the laryngoscope feels like, this is what it's going to look like. Okay, there's the epiglottis, high level glottic ligament, lift up. Good. I also sort of visualize if I get in there and it's like completely contaminated with blood and teeth, or like it's some biker that just had like 5 chili dogs 20 minutes ago. I'm also visualizing exactly what my first move is going to be when I see chili dog coming up at me in the mouth. So that is helpful. And actually they've studied this much like the self-talk. And there are certain things that are helpful in improving or enhancing that capability, and those things include the physical nature of the task. So you're not just sort of blankly running through it in your mind. You actually imagine what the laryngoscope feels like in your hand, what the bougie feels like in your hand. You're imagining the environment, so you imagine a realistic environment of how you're exactly going to perform. So if it's in the ED, you imagine like the ED room. If it's in the ICU, you actually imagine the critical care suite. The timing and sequence of events in order, and finally your perspective. So it shouldn't be like third person watching yourself perform this stuff. You should act like you're right there at the head, opening up the mouth, and what it's going to look like from your point of view. This is also particularly interesting because of all of these skills, this is the one that probably has the most evidence in medicine. So in 2015, Lauria and Hicks did a very kind of interesting RCT where they took anesthesia, surgery, and emergency medicine residents in Toronto. And what they did was they randomized them to various groups. They controlled for level of experience in each group. And then what they did was they took all the groups and they randomized the groups to receive either 20 minutes of technical skills practice and essentially ATLS review before a simulation. And the other group, they just said, based upon whatever your job is or where you're going to be, left side of the patient, right side of the patient, head of the patient, I want you to visualize what your job is going to be and how it's going to look when you're doing your job. And they had taught them this visualization exercise. And interestingly enough, to a blinded panel of judges that were grading team performance and clinical skills during the simulation, the groups that just did the visualization exercise did significantly better. So single center, relatively small sample size, but I think there are methodological limitations to their study. But it shows promise, which I think is very interesting. And at least from a research standpoint, breaking through and actually showing that we can study this kind of stuff was pretty neat. The last piece of the puzzle is focus. So this is actually using a trigger word to focus all of your attention on what you're about to do. So it may seem kind of similar to the self-talk, but it is distinct in the fact that the goals of what you're trying to do are fundamentally different. The trigger word, or short phrase, is designed to hone your attention on whatever task you're doing. So, for example, like when I was giving the RSI example of visualizing and whatnot, when we're ready to go and our checklist is finished, I say the word to myself, focus. And that hones your attention on the skill that you're about to do. That is important. That is, in fact, critical, because from what we understand about how your brain attends to things, the analogy we tell people is your mind's attention span is like a flashlight. It can either be very wide and broad and diffuse, which is helpful in some situations, like if you're out in the middle of the woods hunting or something like that. You want to maintain broad situational awareness of what's going on. Or it can be really sharp, bright, and focused. As it turns out, with specific skills that demand 100% of what your brain's attending to, you need to be focused. If you're distracted and if your attention span is diffuse, you are more likely to commit errors and you are less likely to successfully complete a task, as compared to if you're not distracted and your brain's attention is entirely focused on whatever task you're trying to do. Whether it's kicking a soccer ball or putting in a chest tube, focus, attentional focus is critical. So, by using this trigger word, it reminds your brain to essentially forget about what else is going on for the first during the skills procedure, and focus all of your attention on what you're doing. So, how do we actually incorporate these skills into training? Well, this is kind of very important. And I'll start out with another story. While we were preparing for dive school, we did another activity called ditch and dawn. Another fantastic euphemism for tread water with a 16-pound weight belt with your hands up out of the water until you're ready to pass out, then dive down to the bottom of the pool and rearrange everything, take off your weight belt on the bottom, and then come up to the surface and don't pass out. That is ditch and dawn. And so this was a miserable activity. We all hated this. And one particular day, one of our instructors decided that we would do this for a very extended period of time. And as we got to the side of the pool after repetition like number 6 or 7, and dudes were like ready to pass out, and we thought that he was Satan incarnate, the instructor came over and he's like, I'm not doing this to hurt you guys or kill you guys. I swear to you. We're doing this because when you're in the middle of the Atlantic Ocean and there's an 8 or 10 foot sea, that's not the time to figure out that you have a problem or you're unable to control your physiologic response to this particular stressor. I want you to figure it out now in this pool. If something else goes wrong, we will rescue you off the bottom of the pool. Now is the time to train this stuff. We are giving you opportunities for challenge now so that you don't experience them later. And that completely changed our perception of what was going on. We still hated the guy, and we still did not want to do another repetition. But it changed the whole perception of what we were going through from they're trying to kill us and make us miserable and they hate us to they're really, in the end, trying to help us. This is an opportunity to practice various techniques, whether it's actually finning or treading water, or the psychological techniques to overcome these situations now in a perfectly clear pool, as opposed to dying in the middle of the Atlantic, which is suboptimal. So I think a reasonable process for trying to do this is something we call stress inoculation or stress exposure training. And I want to harp on this because I think there's great misconceptions about this entire process because people think stress inoculation training is just taking residents or nurses or paramedic trainees and sticking them in really difficult, really challenging scenarios with the lights going out and smoke and people screaming. And that's crap. That is not what I'm talking about. That is not stressing people out when they don't have the skills, they haven't been tried, just overwhelming them with stressors. It is very entertaining, as it turns out. But it is also, from an educational standpoint, completely worthless. So that is not what I'm recommending. There's several goals, this whole training paradigm, which is, number one, to gain familiarity and knowledge with how you individually respond to these situations. So for example, like I know that I actually experienced auditory exclusion fairly early on as I'm getting stressed out. So my partner or one of the physicians will be saying something, and I know that when I'm really sort of getting to the edge of my performance level, that I will forget what they're saying. They'll literally tell me something, and if they ask me after whatever the resuscitation is over, I won't remember it. So, like, I know for me, that's something I have to pay a lot of attention to, like making sure that someone's not telling me that before we push the induction medication, the blood pressure is 60 or something. To develop and practice those task-specific skills. So those psychological skills are just that. They're skills. Athletes practice these every time they go to the pitch, every time they get on the hill. You have to actually practice using these and applying these in your context for them to work. If you just like listen to me here and then expect that tomorrow you're going to apply this stuff, no problem, it won't go so well. You have to practice them. And finally, to build confidence. And this is critical. The way you structure the training has to be so that over time, you show people that they can apply these skills and they can apply these techniques and be successful. Building their confidence is key. So there's 3 phases. The first is exactly what I'm doing here to you, information provision. You're adjusting people's expectations. You're telling them that it's totally natural for people to have auditory exclusion, for them to lose fine motor control, for their cognitive bandwidth, their ability to process information, to shrink when they're stressed out. And that's okay, because that is a normal part of human physiology and how we all function. Just doing that, just providing information to people and doing that actually improves their performance, as it turns out, because they feel okay with understanding how they're feeling and what's going on in their head. The second step is the most overlooked step. It's very easy, I get it, because of time constraints and money, to just overlook the long skills training and psychological development process and skip right to really stressful scenarios. It won't work, okay? What you have to do is practice these skills, and deliberate practice. So you have to practice placing central lines and practice doing intubations and have very well-defined goals. The practice has to be focused and repetitive. You do have to increase the difficulty over time, but slowly. You have to get feedback, both quantitative, so actually preferably video recording things and seeing how the time goes, seeing yourself do those skills, and qualitative from an expert who's done it many, many times to help them improve and meet their quantitative metrics. And finally, phase 3, which is the application of practice. So this is when you slowly amp up the stress. As they're successfully completing tasks, you make things harder. That could be like the classic mannequin, blow up the tongue so it's a little bigger in the back of the oropharynx. It could be inducing equipment errors. It could be adding support staff that are not terribly supportive. However you want to do it, but it has to be slow, incremental over time, and that's where the art of being an educator comes in for those people who are supervising to figure out, is it time to crank the stress up or maybe even ramp it back a little bit. So there are certain limitations to what I'm telling you right now. First of all, it has to be individualized. Unfortunately, the various psychological skills, like what psychs me out might not psych someone else out, right? I'm probably perfectly comfortable jumping out of an airplane with a parachute. You might not be. I will freak out if there's like a sick OB patient coming in, maybe not freak out, but not be very comfortable if there's a sick OB patient with twins at 32 weeks coming in. Someone who's, like a maternal fetal medicine specialist, that might be their bread and butter, right? So these various skills have to be individualized to your experience and your environment. You still have to train the technical skills. Please, sweet 6-pound, 8-ounce baby Jesus, please do not walk out of here thinking that I am suggesting that we take time away from our traditional training modalities to teach people emergency medical skills and like sit around and play the guitar and hold hands and sing Kumbaya and imagine ourselves getting better and we're going to be better providers. That's crap. I'm not suggesting that at all. You still have to train all of those practical skills, those technical skills to get better. What I'm suggesting is that we just sprinkle in some of these psychological and performance skills. And finally, we have to have ways to incorporate and practice them in a daily life. If you just sort of set them up for simulation and you don't come up with a way to make them universally applicable to all of the skills of the emergency department or the ICU, they won't be quite as effective. Lastly, the limitation is it hasn't been studied yet. So this precise group of 4 skills to improve performance in emergency medicine hasn't been studied yet. But our friends up in Canada, in Toronto, again, are recruiting residents as we speak for a randomized controlled trial of stress inoculation. So I think we can apply these skills to improve our performance. I think a reasonable way to train people to do this stuff is to incorporate these skills into stress inoculation. And I think it's important because we've all been there. I mean, at 2 in the morning when things aren't going right, the resus is kind of rocky, there's this gap, this chasm between ideal care, what the evidence says we should do, and how we imagine smoothly going in our minds, and how it actually goes, right? And I think at least a part of that is understanding how we perform, how we deal with stress, how we think in these situations, and how we act. And we won't be able to achieve that ideal until we begin to tackle not only the science and the evidence base behind what techniques and what medications work, but also the evidence base behind how we act and how we think. So I think we need to apply these skills and research this stuff because we owe it to ourselves, we owe it to our colleagues, and most importantly, we owe it to our impatients to be the very best every single time we step off the helicopter or step into the resuscitation. So thank you guys very much for your time. I really appreciate it. If you think I'm blowing smoke, feel free to go ahead and check me out and encrypt the human factors column that we do. And if you're interested in the specific list of references for this talk, you can check out this QR code or go to this website, and that is the PDF with the 50, 60 something references for the talk. So thank you guys very much, and boom, there you go.
Can somebody man a timer without me?
You're going to start messing with it. We're going to give you a little, oh no. No.
All right. Good morning, everybody. My name is Meghan. I am currently an emergency medicine pharmacist at the UMass Memorial Medical Center in Worcester, Massachusetts. My Twitter handle on the screen here is EM Farm Girl. I am going to be tweeting out the slides as I go through my talk, so I'll let you figure out how I'm doing that, because you can see both my hands right here, but it's magic. And I wanted to remind you about the hashtag for the conference. It's STOEM18. We do have more gift baskets, right, Peter? So we're going to be, so the top tweets for the morning session, if you want to tweet about how annoying you think my slides are, go ahead. If those are the top tweets, you'll win a basket. So that works out. So I had this experience a few years ago where I was asked to give a talk on drug shortages at a conference, and it was probably one of the worst presentations I've ever given, because I think inherently drug shortages are really boring. So I'll just preface it with that I'm not going to be talking about drug shortages, blah, 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 they're terrible. What I thought we could do today is kind of walk through what my journey has been in terms of how we experience drug shortages and looking at them from a different perspective. So I don't think that I have any formal objectives, but what I want to do, hopefully by the end of this talk, is give you some perspective on looking at drug shortages so that they're not all 100% negative. Yes, we know they're bad, but maybe to talk about some different ways to look at them. So we'll start with some data, really boring stuff, but this is data through 2013, and this is all stuff that we know, right? We are seeing drug shortages in our practices that are at unprecedented levels. So this is data through 2013. I think if you were to extrapolate this out through present day, you would see that this is increased on that similar trajectory, that drug shortages are more and more prevalent. You're seeing them all in the news outlets and certainly in regular communications from your hospital. And following the principles of economics, we know that as you decrease the supply of any potential drug or medication, the demand is going to go up, and this is going to have some big implications for our health system and hospital pharmacy budgets. So this was a survey done from hospital pharmacists published in the American Journal of Health System Pharmacy back in 2011, where they asked hospital pharmacists what sort of things are you seeing in your practice as a consequence of drug shortages. And again, I think a lot of this stuff is obvious, but I thought it was helpful to review it. So the first bar at the top there is an increased burden. So anybody who sort of is familiar with any pharmacy department at your institution, you probably get some sort of communication about drug shortages, but there are entire committees, lots of man hours and effort that are put into not just figuring out how they're going to procure drug that's potentially on shortage, but then what they're going to do for a contingency plan, what alternatives are they going to recommend, and then how are they going to communicate that to provider? Are you getting weekly emails? Is there a bulletin board? What is the method that is most effective for communicating that to providers that's also not really overwhelming? So we've struggled with that a lot, and there's a lot of effort that goes into that. As I mentioned on the last slide, you're going to see an increased cost, and this sort of makes sense. But this has blown up hospital pharmacy budgets. Drugs that have been around for years and years and years and are down to one generic manufacturer. Now there's just one supplier, the demand goes up, the cost goes up, and now you're paying an exorbitant amount of money for a medication that's been on your shelf for 30 years. The third bar I will personally attest to. So I think a lot of hospital pharmacists would say that they've been the subject of increased frustration directed at pharmacy. And I'm not sure if any of you would admit it, but you might have experienced some frustration at the pharmacist when they tell you, we don't have any bicarbonate for this patient who's arresting in front of you. And I don't have any in the code card, so sorry. So there's a bit of a shoot the messenger phenomenon because you're frustrated that you don't have access to the medications that you think that you need to take care of your patient. The fourth bar is that it's changed practice. And this is where I think there's some potential that we'll explore a little bit later on for a silver lining. So we think inherently that our standards of care, if those are not available, like bicarbonate for cardiac arrest, that is going to be an inherently negative experience. But we'll talk about where there's some potential there for growth and exploration. And then the last line, when it compromises care, this is the stuff that grabs the headlines. When cancer patients don't have access to their first-line chemotherapy regimens because of a drug shortage, that's the kind of stuff that gets people's attentions. And this is where we see New York Times headlines and saying that like, oh, cancer patients are dying because the evil drug industry is making drugs short and they don't have access to the medications that they need. So I thought it's helpful for me as I move through a drug shortage and as I reflect on some of my past experiences to visit the 5 stages of grief. Because I think what I've seen in my practice over my long and storied career is elements of each one of these 5 stages of grief as it pertains to drug shortages. So the first stage is denial, right? So thinking that there's no way that we can be short on sodium bicarbonate, right? Like, that doesn't make any sense. It's not going to affect me. There's no way, because that's crazy, right? So I have this phenomenon, obviously, with sodium bicarbonate. I think it's the best example. But providers saying to me, like, why can't you just go to the store, get some baking soda, do some magic in the pharmacy, however you do that, make it sterile, and then bring it to me, right? Because that makes sense. And that's what I do as a pharmacist. I get out my mortar and my pestle and I grind it up, and I bring you bicarb because it doesn't make any sense that this ingredient that is on many kitchen shelves would be short to the point that you don't have access to it for your patients. And the popular media didn't do much to help us. So this was a story from the New York Times in May of 2017 saying that this vital drug, this life-saving drug, is low, and this ingredient is on many kitchen shelves, right? So, so I don't think it did much to help our case that like, yes, no, this is an actual drug shortage. I can't go grab some baking soda from the store and make it sterile for you. This is something that we actually have to deal with. But I will say, this was an opportunity for us to reevaluate some old practices where looking at, okay, so bicarb has a number of indications in the hospital. Where are the situations that it actually makes benefit, and where are the situations where maybe it doesn't have that much of a benefit? So in my own practice, working in the emergency department, sodium bicarbonate has been removed from the ACLS guidelines for cardiac arrest for a long time. It is not routinely recommended for cardiac arrest. Now, there are specific situations where you could consider it, but for the routine cardiac arrest, this is not recommended. And I would say before we experience this shortage, I've seen a number of times where you get a cardiac arrest comes through the door, you're in the resus bay, you give the patient a few rounds of epinephrine, you do compressions, and then you get into the kitchen sink approach, right? So you say, oh, I want bicarb, I want calcium, oh, let's give another bicarb, and then 2 minutes later you're pronouncing. And that bicarb didn't do anything, and it's not likely to do anything. And we have evidence to suggest that bicarb is not routinely helpful, and in some cases, it can actually worsen the acidosis for patients who aren't ventilating appropriately. So what this shortage did is it allowed us to kind of put a critical lens on that and say, okay, should we really be doing this kitchen sink approach for every arrest that rolls through the door? Because what we had to do now, as Dr. Babu points out, she's a toxicologist I work with at UMass, she said, okay, so if we're using bicarb for every arrest that rolls in the door, we're not going to have it for the next situation where it really would make a difference. The next aspirin overdose, the next TCA overdose, where it really could have a benefit for that patient, we're not going to have it if you're using it in every code card. And then this extended to other indications as well. We know that sodium bicarbonate is not really all that helpful for preventing contrast-induced nephropathy. So it allowed us to peel back on some of these indications that we sort of knew deep down it wasn't all that helpful. Sometimes we were doing it anyway, and it's allowed us to streamline a little bit and really kind of practice what the evidence is suggesting and help out with a little bit of that knowledge translation. The next is anger. And I think that I was trying to find a side profile of Peter's face that I could put up there, but I couldn't manipulate some of the pictures like you guys did yesterday. But I would say that this was something I experienced pretty often when we send out these regular communications letting you know all of the new drug shortages for the week. So this week we don't have lidocaine. This week we don't have lidocaine with epinephrine. So any of the procedures you're going to try to do at bedside, we just try to figure out how to do it without them, right? So there's definitely some frustration that we talked about in that survey can be directed either, at your computer or at the pharmacist. And this was something, for a real world example that I saw a few years ago with the phentolamine shortage. So for those of you who don't know, phentolamine is a vasodilator, and we use it for patients who might have experienced extravasation reactions with medications like vasopressors. So if you extravasate a vasopressor, you can inject phentolamine right around the area to vasodilate and prevent some of the tissue damage. It's really the only drug that we have had prior to this to do that. And so when phentolamine was on shortage, there was a bit of a freak out, a bit of a panic saying, what are we gonna do for these patients who might have an extravasation of something like norepinephrine? Are we just gonna let their arm fall off? Do I have to amputate because there's such extensive tissue damage? I don't have any other options. But what's interesting about this shortage is that it created some conditions that we wouldn't have had otherwise, and we got really creative. So with necessity being the mother of invention, shortly after this, I started to see some case reports coming out of utilizing topical nitroglycerin ointment for extravasation reactions because it's a vasodilator, right? It works similarly to phentolamine. And so I started to see case reports and case series and some successes of utilizing nitroglycerin locally for these reactions when they didn't have access to phentolamine. And it's interesting because this is not something that we might have explored otherwise, right? And so obviously, if you have access to phentolamine, that's going to be your standard of care. But now, because of this shortage, we got a little bit creative. We started looking at a new use for an old drug, and now we have another tool in the toolbox, which is sort of comforting to know. The next stage is bargaining. And this is kind of an interesting phenomenon that I've watched happen as we figure out contingency plans to deal with shortages. Is what I mentioned previously, you could think about restricting a drug like sodium bicarbonate based on indication. Okay, we're not going to use it for contrast-induced nephropathy anymore. We're going to use it just for cases like aspirin overdose. But you could also restrict it based on service. So this was a contingency plan that we had for droperidol when I was practicing up at UVM. You could see no change, no change, no drug, no drug. But for a long time, droperidol hasn't been widely available in the US. And the contingency plan that we had at UVM was that this was going to be restricted to anesthesia. So anesthesia's indications for postoperative nausea and vomiting were sort of given precedence over, say, the ED's need to use it for a violent and agitated patient or an intractable migraine. So it kind of feels not that great to have one provider group saying to another provider group, my use of this drug is more important than your use. But it's a bit of bargaining that happens. The next stage is depression. And we're almost to the end, but we have to go through depression first. And this was kind of a funny thing that happened a few years ago with the 2015 ACLS guidelines for adults with cardiac arrest. For those of you who aren't familiar, prior to the 2015 guidelines, they listed vasopressin as an alternative to the first or second dose of epinephrine for patients, adult patients with cardiac arrest. And in 2015, the AHA removed vasopressin from the adults with cardiac arrest guidelines. So I was practicing at UVM at the time, and I sent out an email to providers just letting them know, hey, these are the top 5 changes to the algorithm. I just want to let you know. And I got a lot of really strong reactions. People saying, why are they taking all these drugs away from me? You took away bicarb in the past. You took away atropine in the past. It's like a kid and you're taking away all of his toys, right? So really upset, and they thought that I was doing this, but they thought I was taking away all of their vasopressin. But in fact, I just had to have the conversation and let them know that, look, okay, so the ACLS guidelines are not necessarily intended for ED physicians, right? There's a lot broader audience. And what they had come to was that vasopressin didn't offer any benefit over epinephrine for patients with cardiac arrest. And so because there was a lack of benefit and they just wanted to streamline the process, and in the back of an ambulance per se for pre-hospital personnel, it was going to be a lot easier for them to remember, just be able to do Bristol-Jet of epinephrine rather than try to deal with drawing up multiple vials of vasopressin when vasopressin didn't really offer any benefit. So we weren't in fact taking it away, but interestingly enough, at the same time that this all came out, the manufacturer of vasopressin changed, and they decided they were going to increase the price exponentially and also make it a refrigerated product. So it became really challenging for us to keep it in code cards, and this offered us a really nice excuse to say, okay, it's not the algorithm anymore, we're not going to keep it in the code cards. But in fact, we still had access to it in the emergency department if the providers wanted it. The last stage is acceptance, and I think there's another couple of silver linings that we can see with drug shortages in research and publications, and looking at what I would call natural experiments that wouldn't have been created outside the setting of a drug shortage. So I've highlighted 3 papers here. The first is on calcium gluconate shortage. So this was an intensive care unit that had a calcium replacement strategy and then went through a calcium gluconate shortage. So what they did, they needed to become more restrictive with their calcium replacement after the shortage because they didn't have access to it. And they basically just compared their outcomes before and after. Now, I will fully acknowledge there's lots of limitations to a study like that where you're doing a before and after, and there's lots of things you can't control for. But they found what they thought was an association with better outcomes in the more restrictive calcium strategy. So this was an experiment that probably wouldn't have been undertaken otherwise. They found they actually had better outcomes because of the shortage, or at least the authors claim. The second study here is among patients who underwent coronary artery bypass grafting, and after surgery, because of a propofol shortage, they had to change their strategy for sedation. They ended up putting patients on dexmedetomidine instead. And they, again, sort of did a before and after study, and they found that even though the upfront drug costs were higher in the dexmedetomidine group, the patients had a shorter duration of mechanical ventilation than compared with patients who were on propofol. So again, found that, okay, here's an alternative therapy that might actually be better for patients, and the overall cost for the patient, because of the lower duration of mechanical ventilation, was lower in the dexmedetomidine group than the propofol group. And then the last study is a Cochrane review. This is probably the one that's nearest and dearest to my heart. It's comparing rocuronium and succinylcholine for rapid sequence intubation. And this is something that came out of a shortage of succinylcholine that we experienced a number of years ago. So, as I'm sure a lot of you know, succinylcholine has long been considered the gold standard paralytic for adults needing rapid sequence intubation. Well, a few years ago, when we didn't have access to succinylcholine, providers were sort of faced with needing to get comfortable with another agent. And what they did in this Cochrane review is they compared different doses of rocuronium and succinylcholine and looked at what the intubating conditions were between the two groups. They found that among patients receiving higher doses of rocuronium, so the 1 to 1.2 milligram per kilogram range, had similar intubating conditions to patients who received succinylcholine. And the interesting thing about this is that some providers discovered that rocuronium, in some respects, is a lot easier to use because all of those warnings and contraindications about hyperkalemia, you don't have to worry about with rocuronium. So that checklist that you sort of have to run through, do they have CKD? Have they been down for a long time? Can we get a K? None of that you need to worry about with rocuronium. Obviously, one of the other differences between the two paralytics is a longer duration. So succinylcholine, you have maybe 8 minutes of paralysis, and rocuronium somewhere around 40, 45 minutes. And in some cases, this can actually be helpful. If you have somebody where you need to facilitate diagnostic imaging, you have a CT scan, they're moving around too much. And as long as you make sure that you have adequate post-intubation sedation, the 40, 45 minutes of duration with rocuronium might actually be helpful. So again, these are all things, papers, publications, research, that came out of different drug shortage conditions that we might not have had a chance to evaluate otherwise. Most recently, at my current institution, we've been dealing with the metronidazole IV shortage, and there's some obvious implications here for antimicrobial stewardship, making sure, okay, do you actually need anaerobic coverage for whatever this infection is that you're trying to treat? Is there an opportunity to change from the IV formulation to the PO formulation? But it's also, what I think is kind of cool from a pharmacist's perspective, is helped us fine-tune the dosing a little bit. So, as I'm sure many of you are familiar, reflexively we dose metronidazole every 8 hours for pretty much every indication, but there are very few indications where you actually need to dose it every 8 hours, those being maybe C. diff and maybe intracranial infections. But for most other infections, we can actually get away with dosing this every 12 hours, and the half-life of metronidazole in most patients is around 10 to 12 hours. So it actually doesn't make sense for most indications to dose it every 8 hours. And so one of the strategies that we've had at my current institution is to sort of fine-tune the dosing, dose it how it probably should be dosed, and this has come out of our strategy for dealing with the IV metronidazole shortage. So in summary, I do think, while on the surface drug shortages can feel like an inherently negative experience, I do think that they offer us an opportunity for some creative thinking, some ways that we can look at new uses for old drugs, like that topical nitroglycerin for vasopressor extravasations, and reevaluate old practices. So we know, sodium bicarbonate, for example, is not routinely recommended in the setting of adults with cardiac arrest, but this drug shortage has allowed us to really kind of put a critical lens on that and say, are we practicing what the evidence in the most recent recommendations state? So in summary, I hope I've given you a little bit of a different perspective on the way to look at drug shortages, so it's not all bad. There are some potential silver linings.